What better chapter for me to be looking at you and you looking at me than when we talk about special senses? So let's look at our lacrimal structures. They're located above the eyes, and they excrete tears into the eyes through lacrimal ducts. And this with spontaneous blinking, which is about 15 times a minute, bathes the eyeballs in tear fluid. The tear fluid provides oxygen and nutrients to the cornea, and this is where we absorb medication, through the lacrimal duct. So when we start giving medication, that's where it's absorbed. Excessive fluid production, tears flow from the eyes. Increased tear production can occur during trauma, stress, emotional stress, irritation. Decreased tear production occurs to some extent with aging. That leads us to dry eye drops. By the way, don't use Visine for more than 3 days in a row. I know it may take away the redness in your eye, but because it constricts the blood vessels, that's going to constrict the blood flow to your eye and can eventually lead to injury. So that's just a little 911, 411 on the eyeball. All right. So this is anatomy and physiology of the eye. It's just a little rundown of the external structures and the visual pathway. All of these is which we will be talking about. All right, so let's talk about the sclera, and that's the tough outer layer of the eyeball. It's white, opaque, and then it has a clear covering called the cornea. The cornea allows light to enter the eye for vision and provides about 65 to 75% of the focusing power of the eye. So then let's go to the choroid. Now, choroid is important to know because it's the middle layer. And this middle layer between the sclera and the retina contains connective tissue and is rich in blood vessels that deliver nourishment to the retina and back of the eye. The front of the choroid and behind the cornea is the colored part of the eye called the iris. And the hole or black spot in the middle is called the pupil. Now, what is it that dilates and constricts? Well, it is the iris. The iris dilates and constricts. So you can have pinpoint pupils, which you've probably heard that term, and that could be related to medication. It could be related to opioids. So it's important to always, when we do our head to toe, we always check that perla. And in that, we're checking the reaction time of our pupils. So dim light will help them do what? Dilate, so that we can see in the dark. We're letting more light into the eye. Then they constrict when there's bright light to let less light into the eye. So then we'll talk about that retina. The retina is the inner lining of the eyeball. It's composed of 2 layers, a sensory, and it has retinal pigment, which gives us all our color. Red eyes, of course, blue eyes, brown eyes. Blue eyes is a recessive gene, by the way. And, you know, isn't that interesting? So all our different colors of eyes are determined before we're even born. Very interesting. All right, so the area at the back of the eyeball contains light-sensitive receptors called rods and cones. Now, a good way to remember that is ice cream cones, colorful ice cream. That is our colored part of our eye. That lets our eye see colors. The rods, our eyes see black and white. And then the optic nerve enters the back of the eyeball and sends visual messages to the brain for interpretation. And when the eye is examined with an ophthalmoscope, The part of the optic nerve that can be seen is referred to as the optic disc. Now that optic nerve goes back to the back of the brain, which is the occipital. The occipital lobe, the way I like to remember that is occipital lobe, back of the brain, where our eyes, the optic nerve goes. That's why moms have eyes in the back of their head. All right, so let's talk about the fluid chambers, the anterior and posterior chambers. Now these are really important when we start talking about some disease processes. So the anterior chamber is filled with aqueous humor, a clear watery fluid. It's produced in the ciliary body and it flows over the lens, through the pupil and out the trabecular meshwork into the canal of Schlemm. Interesting names, aren't they? The canal of Schlemm returns the fluid to the venous circulation. The function of the aqueous humor is to moisturize and nourish the lens and cornea. The production and drainage of the fluid from the eye must be balanced to maintain normal pressure within the eye. So what is normal pressure? Intraocular pressure. Well, we are going to get to that. We're going to talk a lot about that, but let's just say right now 10 to 20. It's normal. So then we have the lens. The lens is transparent. The ciliary muscle relaxes and contracts to change the shape of the lens, and this is called accommodation. To focus on a near object, the ciliary muscle contracts, making the lens curve. For distance, the muscle relaxes, making the lens flatter. And this is kind of where we start doing our PERLA, pupils equal reactive, round, to light and accommodation. So all that PERLA is going to start making sense with the eyeball. All right, the lens talked about, so let's move on. The visual pathway. So the visual pathway, the light enters the eye and passes through the transparent cornea, the aqueous humor, lens, and the vitreous humor. These structures are called refractive media. These refract or bend horizontal and vertical light rays, so the light rays focus on the retina. On the retina, light rays are reversed and turned upside down. So everything at first is upside down. The images are carried as impulses through the optic nerve. And the next picture I'm going to show you, it'll make a little bit more sense. They meet in an optic chiasm. And these are fibers from the left field from each eye that join to form the left optic tract, and from the right field from the right optic tract, and then they join. The images are transmitted to the brain by way of the optic tract. So, well, before we get to the pathway, let's look at this aqueous humor. So you can see the aqueous humor and this isn't a very good picture of that, is it? All right, well, we can see right here the ciliary body that's going to have one of our humors. And then the rest is going to be around this area. So let's go on. This is a better picture. I knew I had a good picture here. So here we've got the aqueous humor right here. And this is the vitreous humor. This is anterior, posterior. This is going to the optic nerve. Then here you can see a little bit closer up the aqueous humor, the cornea, the canal of Schlemm, the ciliary body, and the muscles, and the conjunctiva, or conjunctiva, some people call it. So this is the visual pathway. As light enters the eye, it passes through the transparent cornea, the aqueous humor, the lens, the vitreous humor, and these are called refractive media. And as I said before, they bend horizontal and vertical light rays so that the light rays focus on the retina. So you can see the right eye, left eye, and they form together into that optic chiasm. Then they separate and go into the visual cortex or the occipital lobe of the brain. Very interesting. So what are some age-related changes in the eye? Well, unfortunately, you're looking at it. Skin around the eye becomes wrinkled and loose, which is why there's a fortune in makeup and lotions that you can put to help try to make this wrinkled skin not look so wrinkled. Eyelids usually have some excess tissue. This is as you get older, and that's why a lot of people have eye lifts, just to take away that extra tissue, because it weighs down the eyeballs. It can obstruct vision, but it also isn't attractive, so they have some of that tissue taken away, and then it gives that. Have you ever seen on TV some of these people that their eyes look like they're wide open? They probably can't even close at night. But anyway, the amount of fat around the eye decreases, permitting the eyeball to sink. So some patients look like they have sunken eyeballs. Tear secretion diminishes, and the cornea becomes less sensitive to light. So it can't adjust as quickly as it used to light and dark. So that's why our elderly patients, we have to be very careful and always leave a little bit of light on in the room so that they can see, because it's hard and slow for them to adjust to light and dark. A grayish ring, you may have seen that when you look in some of your patients' eyes. You can tell a lot when you look in your patient's eyes. So I know we just use the pen light, and when you take your pen light, don't hold it in front of their eye for long periods of time. Do it quickly in and out. Watch that pupil constrict, or now we know it's the iris that's constricting or dilating. But just be sure that you take a look at the whole eye, which you can see with your eye. Anyway, there's a grayish ring you may be seeing around the outer layer of the iris. The pupil's smaller and responds more slowly to light. And a word, I put it here in red because it's important for us to know. What's presbyopia? Well, that's farsightedness, and it begins to show around age 40 when they need reading glasses. Yep, like this, reading glasses around age 40, and that's exactly when it started happening. All right, so let's do some assessment of the eye. Oh, I'm sorry, I'm blocking the view of this exophthalmic patient, but you kind of get the way someone looks with hyperthyroidism. So bulging eyes. So when we take the health history of our patients, we want to talk about how's their present health. Have they had any changes? Are their eyes drier? Are they have blurred vision? Do they see rings in their eye, rings around things, or maybe especially at night? Do they have photophobia? Now, photophobia is where you're sensitive to light. That can occur in some disease processes as well, like meningitis specifically, or encephalitis. They get photophobic, sensitive to light. All right, so you want to document all these changes. Why are they here? Well, maybe they've had some changes. Maybe they've noticed some things that are different. Maybe they can't see peripherally anymore. When they used to be able to see someone doing this, they can't see that anymore. Your hands need to be closer, and that's one of the things that eye doctors check for when you go have an eye exam. So you also want to find out about the family history. Are there any diseases of anything? One thing, diabetes. Do you have diabetes? Does the patient have diabetes, or does it run in the family? Also, you want to know about any kind of drugs that they're on. Do they have any neurological disorders, tumors, head injuries? How about a stroke? Have they had that? And diabetes really affects the eyes. It can give blurred vision and eventually can lead to blindness. So we want to do a functional assessment on our patients, and that's on page 50, not page, that's box 58.1. So some signs of eye problems in adults. If you want to look that over, I'll just mention a few here. So do they have difficulty focusing on near or distant objects? Now, I wear contact lenses. I have one lens that's close and one lens is for far away. So sometimes you may see me going like this, depending on if I need to see clear or far away. Do they have any encrusted or swollen lids? Do they have pain? That's important if they have pain. Double vision, dark spots. Do they have a curtain that comes down? Did they have a curtain come down at one point? That's indicative of a disease. Did they have a sudden loss of vision? Do they have any flashes of light? So let's go on to, we've talked about family history, we've talked about some functional assessment. So the reason functional assessment is important here, let me go to the next slide. Functional assessment is, are they exposed to anything in their vision? You know, maybe they were exposed to flashing lights or bright lights in their line of work. And has that affected their daily living? So be alert for activities that might pose a risk to the eye. And when assessing the eyes, be alert for the signs of trouble, which is the box 58.1, which I mentioned. So physical exam. And by the way, always remember to read your put on your thinking cap, because it's good critical thinking. So what are some ways you could assess gross visual acuity when diagnostic charts are not available? I mean, how many people have a Snellen chart at your facility? So maybe you can go far away and hold up a book, and can they read the letters? And if they can't read it, at what point can they start reading it? And that leads me to talk about here the Snellen chart. Now you have a picture of that on page 1145. But what that means, and it's really important that you understand this, that from a distance of 20 feet, they have to read down the chart until more than 2 mistakes are made in a row. So they miss more than 2 letters, because usually a Snellen chart is letters, right? Then a person can read at 20 feet what another patient can, with normal vision, can read at 30 feet. So a person can read at 20 feet what a person with normal vision can read at 30 feet. That gives you 20/30 vision. So normal, 20 feet, what you can read or what a patient might be able to read, which is a little bit further, at 30 feet, 40 feet, 20/40 would be at 40 feet. So a normal person reads at 20 feet. I know I'm repeating myself multiple times, but it's important that you understand this concept about the Snellen chart and about what the eye doctor does when you go get a physical exam of your eyes. So here again, the Snellen chart must be pretty important. I mentioned it now how many times? So person can read at 20 feet what a person with normal vision can see at 30 feet. And that would be 20/30 vision. So what is yours? Do you know? All right, so some diagnostic tests and procedures for the eye. So we can start on page 1146, 1145. On 1146 is all of the tests. So the ophthalmic exam just examines the inner eye through the pupil to diagnose abnormalities. You can administer mydriatic medication if ordered to dilate the pupil so the doctor can see in a little bit better to the nerve. They might darken the room, which will adjust the pupils as well. Refractometry That's on the table on page 1146, table 58.1. Refractometry is determining myopia or hyperopia, nearsightedness, farsightedness. Visual fields. So visual fields is a test what can be seen looking straight ahead. So what can you see when you look straight ahead? What is your field of vision? Tonometry is where we find the normal intraocular pressure, or IOP. As I said before, normal is 10 to 20, but a tonometry test or a pneumotonometer is where they blow a puff of air into your eye, and that measures your intraocular pressure. Maybe you would have had that done when you went to get your eyes checked. All right, so the measure of electrical potential. That's important in detecting retinal disorders. There's a contact lens. They put probes on the contact lens, and then they put that in the patient's eye. That's interesting. All right. Then they would expose that to flashes of light. Now, one thing, notice if it says on the angiography part, that fluorescein angiography, a consent is needed because dye is going to be put into the eye. And there's a really good picture on page 1146 if you want to see a fluorescein angiography, what all the little blood vessels in the eyeball. Then we've got some imaging procedures that can be done, and the Amsler grid test. The Amsler grid test is used to monitor for changes in vision with macular disease. So macular degeneration, that test might be done with that kind of patient. All right, let's look at some therapeutic measures. So eye irrigation, this is kind of important for you guys because you're going to be putting eye drops in your patients. So it's important that you do them right so they get the best benefit for their drops. So in eye irrigation, you gently direct the fluid into the lower conjunctival sac. Now, you make a conjunctival sac by just pulling out the eye a little bit, and it makes like a little sac. And then you want to go from the inner canthus to the outer canthus. So inner to outer. That's really important to remember that. So let me just repeat again under eye irrigation. And it's number 4 in your book on page 1148. So gently direct the fluid into the lower conjunctival sac from the inner canthus to the outer canthus or the outer corner of your eye. So that's really important to remember. All right, so topical medications. So place your finger below the lower eyelid down to expose the conjunctival sac, and you create a pouch. And that's where you give your medications. So irrigating, you're going to direct the fluid into the conjunctival sac and go from the inner to the outer. And then with eye drops or medications, you're going to make that sac again, that pouch, and you're going to put medication in there. And mydriatics dilate the pupils. Miotics constrict the pupils. So that's important to remember. It's important to know how to put eye drops in and how to irrigate the eye. So you might want to refresh yourself on that. Creating that conjunctival sac, pulling the eye out. Don't want to do it too much to my fragile eyes. All right. When you instill eye drops, be sure they're room temperature. If they were kept in the fridge, you want them to cool. You can rub them between your fingers, between your hands to warm them up a little bit. And then have the patient tilt their head back, and then you'll put the eye drops in. And you might have them stay that way so they don't come rolling down their cheeks. So important installation of eye drops. All right, so let's talk about protection of the eyes and vision. So again, I mentioned this before, I know. After the age of 40, eye exams should be done every 2 years, including testing for glaucoma. So every 2 years after the age of 40. It's important to know that. So what vitamin is good for the eye? Vitamin A. That's right, vitamin A. So we want to prevent the eye from injuries, so those protective goggles are really important. For nurses, we don't get secretions in our eyes, but there are some jobs that they need to wear protective goggles to prevent injuries to the eyes. Most facilities have an eye wash station in case something got in the eye. When it's really windy outside, things can get blown into your eye, and you want to irrigate your eye so that whatever got into your eye could be just a piece of dust, but it feels gigantic and it really hurts your eye. And you don't want to rub it too much because then you're scratching your cornea. So rinsing out of any outside, even if it's just a piece of dirt, or if it's anything bigger than that, you want to rinse it out with water. All right, so just remember you want to teach your patients about going to the eye doctor every couple of years, because eyes can change. And when they do, if they start changing too fast, that's a sign of some disease. So let's talk about visual impairment. So the effect of visual impairment, the loss of vision can trigger a grief response. Imagine if you can't see. It's one thing if you're born with no vision. You don't know what it would like to see. But if you lost your vision, that can trigger a grief response. People who experience progressive loss of vision experience anticipatory grief. They know they're going to lose their vision. They anticipate the vision loss with anticipatory grief. So, special nursing care of the visually impaired. So, that's in box 58.2. Now remember, we have boxes and we have tables, so be sure you go to the box. All right. Interventions. So interventions, inadequate knowledge. When a visually impaired person is admitted to a facility, they don't know where anything is. So be sure you orient them. Let them know, let them touch where things are. Depends on how limited their vision is, but they need to know where things are located. So orient them with their hand if need be. I always think of Helen Keller. I don't know if you saw that movie, but Helen Keller, they just took her hand and showed her where everything was. Sometimes that's what you have to do to some of our elderly patients. So it's important for their coping to have their eyeglasses or a magnifier. If they can't see, offer them a magnifier. Maybe a family member could buy them one. Maybe they didn't know such a thing existed. Older people tend to become confused, and if they can see, then they can see the light, so to speak, and they don't feel so confused because they can see what's around them. Not being able to see things around you, only see blurs, it's confusing. So things that you can provide to help with their coping is not only their eyeglasses, audiobooks are great, large print books, and also things in Braille. They also might have a guide dog in potential for injury, so they might have a dog that sees for them. That seeing eye dog, it's now been advanced that we have a lot of guide dogs that do a lot of things for patients. So potential for injury is don't move the furniture around. It's not a funny joke. And don't put their personal effects, when you go to clean up and straighten everything up, don't move their hairbrush away where they can't find it. So if you're going to move things around or organize things, talk to your patient about that. Let them be in control of their belongings, because it makes them feel more secure, and then they're not at potential for injury by trying to reach and find something, and then they end up falling out of bed. All right, so the inability to perform self-care, they can't see. They can't see the finer areas to clean up, so they can't see to button. Their buttons might be discombobulated. So these are interventions that we can help them with bathing and dressing, moving around, if we had a walker, or even like a cane to help them feel their way around. All right, let's move on. It's a scary thing to not be able to see. I can't imagine. It's bad enough when things start blurring, which means I need to go to the eye doctor and get stronger glasses. All right, so some anatomy and physiology of the ear. So we've got the auricle. Now this is on page 1154. The auricle or pinna of the ear, that very top of the ear. Some people have that pierced, the pinna. That's where the little curl is. We have innervation. Many nerves innervate the ear. So ear pain can be indicative of many things. It can be indicative of an ear infection. It can be indicative of inflammation of that 7th cranial nerve. So it's very important. Facial pain is protected in the canal by a thin bone covering. So even facial pain can be related to ear pain. Even tooth pain. You think it's a toothache, but it's really an earache. They're all closely related. Then we've got lymph drainage. Lymph nodes are located in front of and behind the auricle, down the ear. So right in here we have lymph nodes. In the presence of ear infections or other infections, we might have some enlargement of those lymph nodes. Then we have the external auditory canal. That's what's lined with the cerumen or the wax. And that's where we can get that waxy buildup. Now in the elderly, it gets more dry, but it can still get built up. Now, it talks a lot about not putting things in the ear. I know we probably all use Q-tips, but not supposed to, because it could push wax further into the ear and get it impacted. My mom used to put a hairpin in her ear to clean out wax. That's not a good idea either. You can puncture your eardrum or your tympanic membrane. So not a good idea. The tympanic membrane, as I was saying, at the end of the external auditory canal, vibrates. Tympany, like a drum. The middle ear has bones. They're little teeny bones. They're really ossicles. The malleus or hammer. The incus, which is the anvil that is hit by the hammer. And the stapes, which is the stirrup. The function of these bones is to conduct the sound waves transmitted by the tympanic membrane. So they're like hitting the it's like a whole orchestra in your ear, right? You've got the drum, you've got the hammer and the anvil, and it's making sound waves for you to hear. All right, so the eustachian tube equalizes pressure. This is when you go up in an airplane or when you go over the hills and you get that pressure in your ears. That's your eustachian tube. And it takes a minute for you to equalize the pressure, and you may have to swallow, you may yawn, and that helps equalize the pressure from inner ear to outer ear. All right, the inner ear has the membranous labyrinth, and a labyrinth is not like a maze. If we were in real life, I'd bring in my labyrinth. It is just a pathway that goes one way in and one way out. It's not like a maze where you can get trapped. It's more like a snail with a curl. I think it kind of looks like that in the pictures. So the membranous labyrinth has endolymph, which moves. So it's a liquid that moves and changes with your posture. And then you have the bony labyrinth. And that's in your inner ear. See if there's anything else you need to know here. Oh, there's also something called the cochlea, which is a coiled tube that is the receptor end of hearing. One more thing, the organ of Corti, which transmits stimuli from the oval window to the acoustic or auditory nerve. That's really interesting to know. Right, here's just a picture, a really good one, the same one that's in your book. But you can see the cochlea, you can see the hammer, the middle ear. It's divided into external ear, the middle ear, where your tympanic membrane is, and where your malleus, incus, and stapes in the auditory ossicles, and then inner ear. Very interesting, very intricate, right inside your ear. Ear infections, got to watch out for those because those can damage hearing. I'm a child of the 60s. I used to put my head in between the speakers, and I probably have a little ear damage. So let's talk about age-related changes. Oh, here's another picture. Sorry, I did want to put this in here so you could see your eustachian tube. And that goes right down into the throat. So we're really all connected, our eyes, nose, throat. It's all pretty well connected there. All right, the physiology of hearing. Perception and interpretation of sound depends on a complex series of steps. A malfunction at any step can result in some type of hearing impairment. So you can see how the sound waves come into the external canal and goes to the tympanic membrane, vibrates, which vibrate and move the malleus, incus, and stapes. The oval window can move also. And the sensory receptors in the inner ear go to the acoustic nerve, which then goes to the brain and says, hey, you just heard some beautiful music. And then you want to hear some more. You turn your ear maybe more towards that sound. And that's one thing, when someone has trouble hearing, you'll notice they might lean in towards you, or they might lean away if they think you're too loud, or if the music is too loud. So be sensitive to the way these our patients are moving as well. All right, let's get down to that, age-related changes. So skin of the auricle becomes dry and wrinkled. The cerumen, or the wax, declines, and the wax is drier. The hairs, suddenly we got hairs in our ears, and hair starts going away from our head. Not fair. But we have hairs in our canal. They become coarser, longer, especially in men. You've probably seen hairs sticking out of men's ears. The eardrum thickens and doesn't vibrate as well as those bony joints start to degenerate. Degenerative changes, you get atrophy of the cochlea, the cochlear nerve, the organ of Corti that affects sound, speech, and balance. And that's why some of our patients are very positionally challenged, shall I say. So they need to sit on the side of the bed. It could be medication. It could be their ears. It could be so many things, just age-related changes where they have to get their equilibrium back. So we have to be very careful when we get our patients. Don't just hop them up out of bed. And also for us, we shouldn't just hop out of bed. We can lose our balance, especially with an ear related injury or infection. So some types of hearing loss that are associated with aging. Let's talk about those. So you want to do a good assessment, but first let me talk about those hearing losses. So that's called presbycusis. The type of hearing loss most often associated with age is presbycusis. Now, do you remember what it was called when we have start losing our vision? What was that called? That was a cussus also, right? So remember that cussus is kind of an age-related thing, and whatever that first word is what we're gonna go with. So type of hearing loss most often associated with age is presbycusis. All right, so we want to assess our patients that come to us and ask them, do you have pain in your ear? Now, pain in your ear is called otalgia. All right, it's not enough to find out, do you just have pain? We want to find out what kind of pain is it? Is it really pain, stabbing, sharp, dull, aching? Or is it, do you suffer dizziness? Or do you suffer tinnitus, ringing in the ears? A lot of patients experience that. Vertigo, dizziness, nausea, vomiting because of all that room spinning around. And they have trouble with balance. So another thing we want to find out is, have they taken any medications that could have affected their hearing? In other words, have they taken ototoxic drugs? Now, aspirin can be an ototoxic drug in larger doses, not your mini 82 milligram doses that we give our patients, but in the older days, patients took aspirin before we had NSAIDs for pain. Now, aminoglycosides. So, and I say here, note your pharm capsule. So what page is that on? Should have had that marked. I thought I did. So the pharmacological capsule is some drugs, and this is right under, right after the health history portion. It's the orange. Some drugs, including aspirin, are ototoxic. Signs and symptoms of ototoxicity are tinnitus, ringing in the ears, hearing loss, dizziness, and ataxia, that inability to feel your way in space, right? You just feel, you have an unstable gait. Do you remember the name of that word? How your body knows where you are located in space? Do you remember that? I think we learned that in fundamentals. Proprioception. It's one of your senses. So it's how you feel, how you know where you are in relation to other things. Proprioception. Good word to know. All right, so we talked about otalgia. We understand what that is. It's important to know pain in the ear. Ototoxicity can occur with with medication. I had a patient that had Lasix ototoxicity. So there's other medications that can cause that as well. These are the most known ones, but anything in a high dose that a lot of times is given to save someone's life ends up injuring something. That can happen. All right, a functional assessment, exposure to loud noises, hippie, amplified music, firearms. Do you shoot guns, rifles, that loud noise? Do you go to the gun range? They usually have you wear headphones, right? Or what do you call it? Something to stifle the sound, right? So you don't hear so much noise. If you do take your kids to concerts or whatever, they should wear headphones so the sound's not so loud to injure their little eardrums. All right. So have they been exposed to anything like that? Or even noisy machinery? Did they work in a machinery facility where they had a lot of noises going? All right, let's do our physical exam. We want to look at their external ear, the canal. Do we see anything in there? Any bugs? Any roaches? Anything blocking the tubes? You know, now they have those little hearing aids that look like spiders. Have you seen those advertised on TV? So maybe be careful what you see there. All right, so here's something you need to know. When we talk about diagnostic tests and procedures, but before we go to that, I want to tell you what an audiologist is. So an audiologist isn't a medical person. An audiologist or an audiologist or hearing instrument specialists perform tests to determine whether a hearing aid will help a particular patient. So that's an audiologist. Helps the patient with their audio, right? And so it's not a medical doctor. An otolaryngologist is a physician who specializes in diseases of the ears and throat, because we're all connected there. All right. So interesting tuning fork tests. So the Rhine and Weber test. So that's on the next page. There's another test I want to talk about before. Well, we'll talk about the Rhine and Weber, and then we'll talk about the other test. So the Rhine test, this is interesting, and you need to know about these two tests, and I'll tell you why. Because it's about conduction of sound. Conduction through a bone, conduction through the air. Which is louder? Different people can hear different conductions. So in the Rhine test, a tuning fork, if you've ever seen a tuning fork, it's metal, and it has like two little, like a fork, only not 3 tines, it only has 2 tines of the fork. And you hit it to make it vibrate, and then you place the base of the tuning fork on the patient's mastoid bone. So where is that? Back here, right behind the ear. If the vibration is conducted through the bone, the patient can hear a humming sound. When the sound is no longer heard, move the fork so that the tines of the fork are near but not touching the ear canal. So you'll take it from here and move it more towards the ear. Ask the patient if he or she can hear the sound, and if so, report the sound when the sound disappears. So normally, air conduction is better than bone conduction. So that's AC is better or greater than BC. Important to remember that. AC better than BC, air conduction better than bone conduction. And that is in your book under the Rhine test. Then the Weber test, you place the base of an activated tuning fork. Again, you hit the fork and it starts vibrating, and you put it at the midline of the skull. Ask the patient to identify the sound in which the sound is loudest. The side, identify the side which the sound is loudest. With normal hearing in both ears, the sound is heard equally. Now, the sound is louder in an ear with conductive hearing loss. Why is that? Because it's going through the bone, and air conduction is better than bone conduction. So the sound is louder in an ear with conductive hearing loss and softer in an ear with sensorineural hearing loss. So it's important that you remember that. All right. So read through that. Be sure that you understand that with normal hearing in both ears, the sound is equally heard with the tuning fork. The sound is louder in an ear with conductive hearing loss. The conduction is louder and softer in an ear with sensorineural hearing loss. All right, I want to go back and talk about that caloric test. That's pretty interesting. So ears are irrigated with warm or cool water to assess for dizziness. Now, we used to do this in the ICU with patients who didn't have, we were checking to see how much brain function they had, and we would inject cool water into their ear, and their eyes would have nystagmus. They would be shaking back and forth, kind of like a doll's eyes go back and forth. Dizziness is consistent with a diagnosis of Meniere's disease, though. So caloric tests can be used for many different things. So one of the things that the caloric test is used for is to diagnose Meniere's disease. We'll talk about that next chapter. Tell the patient that the ears will be irrigated to assess for dizziness, so they might as well prepare to feel dizzy. The patient may even need or may have taken something, a central nervous depressant, had some alcohol or barbiturates that alter the responses. Examiner will observe the patient for nystagmus, nausea, vomiting, or dizziness. Now, another thing that is tested for, and this is on your table 58.3, is the electronystagmography, and that detects lesions in the vestibule. So in this particular case, the patient would get nothing by mouth. Now, I might tell you here, we have some tests on the midterm, right, that are going to be coming from these lectures. So I'm trying to point out some things that you might find on that lecture, some things that are important to know, also some things that may be important to know NCLEX-wise. So I'll try to lead you to really, really important things to know. All right, so electrostagmography used to detect lesions in the vestibule. Nothing by mouth. Now, of course, the doctor will write that order, but we always want to be aware of what should and should not be done. And the patient should be NPO for 3 hours before the test. No alcohol or caffeine, because we know caffeine makes you dehydrated, for 24 to 48 hours before the test. Now, this sounds awful. The ears are irrigated, and the patient is turned in various positions in a special chair. So it's almost like being on a ride, right, at Disneyland or something. You're just, the Toad's Wild Ride or whatever. You're just turned and twisted around, and that fluid that's in your ears could make you feel dizzy, maybe even make you throw up. So that's an important test to know about, as is your Rhine test, your Weber test, and your caloric test, all things that you may very well see. Okay, let's see what else we have here. Some therapeutic measures. So how do we put eardrops in? So table 58.4 does talk about some drugs that we put in the ear. Sorry, just touched my face. Broad spectrum antibiotics. We can put different antibiotics and softening agents. We might put in some drying agents. Antiemetic type agents can be put behind the ear. Prevent motion sickness. So under irrigation and under eardrops, let's note those. All right. So on page 1160, how do we apply eardrops? Well, I'm going to go to number 1 here. So be sure to use an otic solution. Warm the drops to body temperature, and you roll the bottle between your palms to warm it up. Have the patient tilt their head so that the ear to be treated is positioned towards you, up higher. Straighten the external auditory canal of an adult by pulling the auricle up and back. Up and back. For a child, you pull the auricle down and back. Adult up and back, child down and back. For eardrops. Hold the dropper at the opening of the canal. You don't want it to touch any part of the ear for contamination. Instruct the patient to keep the tilted ear up for several minutes to keep medication there, or you might have to put like a cotton swab to hold the medication in. All right, now let's go to irrigating. Similar. So select the correct solution as ordered by the healthcare provider. Warm the solution to body temperature. Now, if you don't, you might get that nystagmus, the eyes that shake. So you want to just have room temperature, body temperature type of water. Have the patient sit up and hold an emesis basin in case that they feel nauseous during this time. Or just to catch the fluid that comes out of the ear. Either way, right ear. So drape the shoulder under the basin, drape the shoulder with a towel or something like that. Straighten the auricle canal of an adult, up and back. For a child, down and back. Select the solution or bulb with a tip that's small enough to get into the canal. Direct the solution towards the top of the canal in a steady stream, not straight into to hit the drum. And then you might have to repeat that several times. Eardrops may be ordered to loosen any cerumen or wax impacted. And then that basin there is also used for when you wash out any kind of blockage. All right, let's move on to hearing loss. So different types of hearing loss. Again, we're going to talk about the conductive hearing loss, interfere with transmission of sound waves. So if they have conductive hearing loss, don't speak loudly, because bone conduction allows them to hear their own voices. Just think about yourself. You can hear yourself. You're vibrating your own bones. Bone conduction, they can hear their own voice, and that's indicative of conductive hearing loss. Then in sensorineural hearing loss, they can hear sounds but have difficulty hearing their own voice. So they can't, the nerves are damaged. They can't hear their own voice. Then there's mixed hearing loss and central hearing loss. So you need to know those. Again, they're repeated here on page 1162. Before I go on, let me just go back for a second and talk about how important it is if a patient has a hearing aid that it comes with them. Because just like if we can't see, if we can't hear anyone coming up to us. So when you approach a patient, be sure that if they can't hear you coming, you might have to just very softly start to touch them so that they can hear you coming. They can't hear you coming, but they have to know that you're there. So And you might squeeze them just to let them know that, or soothe them that everything is okay. So what I'm trying to get at here is nurses and other healthcare providers need to be familiar with hearing aids and how they work. The patient's nursing care plan should indicate that the patient usually wears a hearing aid. It needs to be noted in the chart, because if they don't have it on, they might be acting confused and you don't know why. So confusion and auditory deprivation, increased hearing loss related to increased auditory stimulus in some older patients might be avoided if they had a hearing aid. So if they have an hearing aid, be sure they have it on. And you know, if your patient, let's say you have a new patient, you don't even know them, and they can't hear you, you might ask them, do you have a hearing aid? And they'll go, oh yeah, it's in the drawer. They forgot. They forgot they had it, or they forgot it was there. So check their bedside table just to be sure if it's there and they didn't know it, or if there's a container there, be sure it's labeled properly with their name on it. Just like we did with dentures, like we do with anything, we label it on the bottom, not on the lid, so that we don't lose it. All right. So surgical intervention of the eye and ear. So we're getting towards the end of the chapter here, and they've combined these two things together because it's essentially the same. It's a loss, it's a sense loss. So they're losing a sense. So the surgical intervention is going to be similar. You're going to do your pre-op focused assessment, and you're going to document any findings that you have. In your interventions, you're going to orient the patient to their surroundings. Be sure always they have their call bell within reach. Sometimes it's not a bell, it's a pad, but whatever it is, be sure that they can have it. If they can't see it, they need to know where it is. All right. They're coming in to have surgery for a problem, so we don't want them to be even more scared because they can't reach us. Right, so as far as orienting them, orienting to the room where things are, and like I said, especially the bell. Post-op nursing care is going to be similar, eyes and ears. We're going to do an assessment, inspect that operative site, and take their vital signs. That's normal, right? We want to check for bleeding, drainage in their site, operative site, their dressing. We're going to take their vital signs. Is their blood pressure high or low? How's their heart rate? How's their respiratory rate? How's their oxygen saturation? Then when we talk about interventions, this is where I want to get careful. So I'm a few pages behind. So in our post-op nursing care, they're at potential for injury. This is on page 1166. So important to remember this. Straining is contraindicated. Whenever you have eye or ear surgery, think about it. If you strain, you're putting pressure in your head. So that's contraindicated in eye or ear surgery. So it increases pressure in both the eye and ear. The patient should avoid nose blowing, again, pressure, coughing, and sneezing. But what if they have to? What if they have to cough? They need to open their mouth so that it's not all pressure inside, that when they open their mouth, that it comes out, it isn't kept inside of their head. So important in post-op patients, prevent increased intraocular pressure with that sneezing or straining. Don't lean forward because that's putting pressure. The gravity is pulling the weight down. Don't lift anything very heavy because again, that's putting pressure. Also lying on the affected side. So after eye surgery, the physician may prescribe limitations on activity, position, or both. The head of the bed should be elevated. The patient may be wearing a bulky dressing or small eye patch. After ear surgery, so you can see on your notes here, it says they both have potential for injury with straining, which is contraindicated, whether it's bending over, sneezing, coughing, straining. In an eye surgery, they might have an eye patch and their head of bed needs to be elevated. That will help decrease the swelling. If their ear is packed and if draining is encouraged, then they want to be on the side of the surgery, right? Because that's going to help the drainage come out of that ear. That is on page 1167, so that you know. It says the ear is commonly packed and covered with a dressing after surgery. A drain may be in place. Only the physician may remove the packing. So always remember that. We might be able to change the outside dressing, but we usually just reinforce, right, the outside dressing of anything. And that lets the doctor know how much drainage has come to the patient. If drainage is being encouraged, the patient is most likely positioned on the affected side. Encouraged. However, if the patient includes a graft on the tympanic membrane, the patient is usually positioned on the unaffected side. So need to know what kind of surgery they had. Always important to know who you're taking care of and what's wrong with them. All right. Let's try a question. After all of that, I'm almost done. So 2 questions. Aqueous humor is produced where? I'll give you a minute. Aqueous humor. Think about where it is. Is produced in the B, ciliary body. So the anterior chamber is filled with aqueous humor, which is clear, watery fluid. Aqueous humor is produced in the ciliary body. It flows over the lens, through the pupil, and out through the trabecular network into the system. Okay, question number 2. Which of the following is not an age-related change in the ear? Give you a second. All right, you're right, it's A. So cerumen production doesn't increase, does it? And it said not an age-related change. So if cerumen production decreases, that's why it's dry, and you might have to clean out the wax. So, all right, well, thank you so much for listening to my lecture. I hope you enjoyed. Have a great day. Bye.